She had 2 previous miscarriages at 27 weeks, so third trimester. She has been having this right breast lump for 1 year already, but she did not seek any medical treatment. Now she's pregnant, so only she brought up about this breast lump. It's quite large, 6 centimeter, ultrasound suspicious mass for 4 centimeter. There's axillary lymph node, biopsy proven invasive cancer, hormone receptor negative, HER2 positive. The lymph node we took a biopsy is negative for malignancy. And case 2, it's a 40 years old, para 2. She was diagnosed with breast cancer 2020. Mastectomy axillary clearance was done. It was locally advanced T3 and 3 cancer. Her hormone receptor positive, HER2 also positive. During the initial staging, there was a sub-centimeter lung nodule. She received adjuvant chemotherapy, radiotherapy, and trastuzumab and tamoxifen until 2022. Follow-up CT scan, the lung nodule appears to be larger, so she was started on second-line trastuzumab medication, and whilst on treatment, she was found to be pregnant whilst on treatment. So think about that. We'll have a look again at these cases at the end. So questions to be asked. Normally we ask, how does pregnancy affect breast cancer and its treatment? So for doctors, because we need to manage the patient. But we also have to ask, how does the treatment for breast cancer affect pregnancy? As we know, chemotherapy, a lot of the medications are contraindicated in pregnancy, and whether the chance of patients getting pregnant is reduced and how to improve chances for them to get pregnant. So pregnancy age-related breast cancer, PABC, breast cancer diagnosed during pregnancy and up to 1 year postpartum, because they still need to take care of the baby, breastfeeding, so a lot of things are involved in relation to the pregnancy itself and the breast cancer treatment. Still the commonest cancer diagnosed in pregnancy in women. In HCTM, our census for the past more than 10 years, I think we have 31 cases over 12 years. They usually present with locally advanced or advanced stage. However, the overall survival and disease-free survival is not significantly different from non-pregnant patients. So if you put them stage by stage, age by age, it's actually the same with non-pregnant patients. But unfortunately, because they're pregnant, they tend to present a bit later. So the prognosis seems to be slightly worse compared to when they're not pregnant. So there are a lot of issues in PABC, psychosocial issue, fertility, family planning. There are young patients, young age group, diagnostic challenge. There are changes in the breast physiology. The breast is more engorged, so it's a bit more difficult to detect lesions on imaging. Radiation risk to the fetus is a concern. X-ray, mammogram, CT scan. Maternal fetal conflict. So whether we're dealing with 2 lives here, so whether we should prioritize the mother or the fetus. The termination of pregnancy is a viable option. And of course, there are concerns about hereditary conditions since they are young. So we need to be concerned about hereditary breast cancer as well. And of course, for us clinicians, we have to tailor the treatment according to the patient's trimester. So treatment timing and modalities plays an important role. There are a lot of contraindications, certain contraindications in pregnancy, during pregnancy and breastfeeding. So detection of pregnancy associated breast cancer. So as I mentioned earlier, they usually present a bit late. Sometimes they mistaken the lump as a pregnancy-related, a normal physiological breast lump. Or if they are breastfeeding, they might think it's galactocele and lack of awareness in the public. And amongst the doctors, clinicians, primary physicians, sometimes there could be delay in diagnosis as well. We tend to treat them a breast mass or breast enlargement as mastitis or galactocele. So given antibiotics, but no follow-up after that. I've seen patients who, I think a few patients already who were treated for mastitis, antibiotics, but later on found out to have breast cancer. And we tend to think that breast cancer affects more older people, so younger patients. We would like to think that it's unlikely for them to have breast cancer, but nowadays it's not so. The youngest I've had recently, 22 years old. So as a rule, investigate any persistent lump if it's persistent for more than 2 weeks. So you have to follow the patient up. Don't just give antibiotics and leave it at that. Imaging might not be optimized, risk of radiation, mentioned that before, and biopsy also may not be optimized. Nowadays we prefer core biopsy as opposed to fine needle aspiration biopsy for all patients, not only pregnant patients. As for imaging, breast imaging, ultrasound is safe and preferred. Mammogram we would order once diagnosis is confirmed. Usually mammogram is done for patients more than 40 years old. The fetal exposure to radiation is negligible. It is considered safe with abdominal shield, but sometimes it may be limited due to dense breast. MRI is normally used for younger patients. However, in pregnancy, the contrast, gadolinium is contraindicated. We can do MRI without contrast, but the image quality is not as good. It may not give you much information. And of course, they have to do it in a prone position, so it may be, it's difficult for pregnant patients. If you have to use it, and then the guidelines suggest that it should not exceed 1.5 Tesla. Chest X-ray with or without abdominal shield, you can actually do without abdominal shield. I think the studies showed that the exposure is quite low, and the abdominal shield sometimes can affect the image quality. CT scan is of course contraindicated because the radiation is much higher, and there's also concern about iodine-induced neonatal hypothyroidism. Same with PET scan, bone scan, anything that involves contrast material. Okay, so this is a summary. I think I got it from ESCO guideline. You can have a look at this later for all the imaging. But basically, ultrasound is the first and the preferred imaging for breast cancer, especially in pregnant women. Okay. As for management, of course, we have to do our MDT, multidisciplinary approach, oncologists, ONG, radiologists, pathologists, sometimes geneticists, surgeon. And we have to time our treatment according to their trimester and also the stage of the cancer as well. So as an overview for breast cancer in general, pregnant or not pregnant, you have to do the triple assessment, imaging, clinical assessment, as well as the biopsy. And then do the staging if indicated, and then we'll discuss the case in MDT. So I normally like to divide the management into two types. Either patients go for upfront surgery, or nowadays we tend to send patients for neoadjuvant chemotherapy or neoadjuvant chemotherapy. So these are usually for upfront surgery, usually reserved for early stage cancer, hormone positive cancer, because they don't tend to respond very well to chemotherapy. So they will go with a surgery upfront, followed by chemotherapy, if indicated, radiotherapy, and endocrine therapy. Whereas if it's advanced or locally advanced stage, HER2 positive, triple negative breast cancer, so we prefer to give a neoadjuvant chemotherapy first because the tumor responds very well. They can get pathological complete response in 50 to 60% of the patients. Then, so downstage the tumor and then go for surgery, radiotherapy, and endocrine therapy. Okay, so having this in your mind, so we need to tailor our treatment to patients. In pregnancy, of course, we need to follow the trimester. I think for surgeons, this is the only thing that we probably need to remember. Surgery can be done throughout the pregnancy, either on the first trimester up to the third trimester. but preferably in the second trimester because risk of miscarriage is lower, but it can be done. Chemotherapy, second trimester onwards, the rest, radiotherapy, endocrine therapy, targeted therapy are all contraindicated during the pregnancy. So for us surgeons, breast surgeons particularly, what are the considerations? So for the breast surgery, we attempt to explain to patients we have two options, either mastectomy, remove the whole breast, or breast conserving surgery. So for pregnant patients, if they are diagnosed in the first trimester, mastectomy is preferred because they will need to go for radiotherapy later. So for those who undergo breast conserving surgery, white local excision, it is a must for them to go for radiotherapy. So you'll see later how this works. So it's more suitable if the breast cancer is diagnosed in the second or third trimester. Breast reconstruction, avoid if possible because the breast is still undergoing changes, so you may not get the appropriate symmetry from the other side. Sentinel node biopsy for the axilla, so this is part of the staging for breast cancer, especially in early breast cancer. The concern here is whether we can use blue dye. The normal sentinel lymph node biopsy will use two methods. Use blue dye, and the other one is radio isotope, which is the technical. So blue dye is contraindicated because of the risk of anaphylaxis. However, technetium 99 is safe. Systemic therapy consideration, standard chemotherapy can be used, so you don't have to switch to a different type of chemotherapy. Usually start in second or third trimester is safe, but it needs to be stopped 2 to 3 weeks before delivery because patient might be immunocompromised during that time. Anti-HER2 targeted therapy, all contraindicated. Other more specialized therapy, targeted therapy is all generally contraindicated. Endocrine therapy, commonly used, tamoxifen, letrozole, contraindicated throughout pregnancy. It can cause teratogenicity, some genital tract anomaly. So if a patient plans to be pregnant whilst on treatment, we need to discuss with the patient. They can actually stop the treatment about 2 to 3 months for washout period before conception. So this has been proven to be safe in a positive trial. So this is summary of agents that can be used during pregnancy or not safe during pregnancy. Radiotherapy, as I mentioned earlier, is contraindicated throughout the pregnancy. However, there are some centers which use more advanced radiotherapy, such as IORT, intraoperative radiotherapy, where they put the radiotherapy ball into the breast into surgery, so that reduces the exposure to the fetus. Or they use proton or electron beams, which I'm not familiar with. So this can reduce the exposure to the fetus and has been used in pregnancy. Okay, so for you guys, so what if you're called by the surgeon to help us in managing this patient? So of course, if they started on chemotherapy, you need to monitor them. I think you start monitoring early anyway, every 3 to 4 weeks to look for any anomalies to the fetus. Aim delivery as per normal, more than 37 weeks, so that the fetus is matured. Stop chemo 2 to 3 weeks before. Vaginal delivery is preferred. You may consider cesarean section in some patients. Steroid can be used for the lung maturity. This is something I found out. You can send the placenta. You can actually have a metastasis to the placenta. Apparently, I've not seen one. Termination of pregnancy usually not indicated. It doesn't improve survival. So some patients might be thinking, if I get rid of this pregnancy, I may get the better or the appropriate treatment. and my chance of having better prognosis is improved. But it's not. So, but in certain situations you may want to consider, especially if there is medical emergency, life-threatening conditions. Inflammatory breast cancer, a very aggressive cancer, you want to start. So inflammatory breast cancer, even though they are in first trimester, we have to give them chemotherapy first. So the patient might have to consider termination of pregnancy. Visceral crisis, pleural effusion, liver failure, spinal cord compression, they need to have radiotherapy. So you may have to consider termination of pregnancy. Breastfeeding, avoiding chemotherapy and targeted therapy, otherwise it's okay. And we have to consider the fetus as well after the delivery. I think pediatrics have to check the blood tests, urine and thyroid function tests. Okay, so management timeline. I've attempted to summarize how we approach patients if they are diagnosed in first trimester, second trimester, or third trimester. So as I mentioned before, it depends on the approach whether you are going for upfront surgery or neoadjuvant chemotherapy. Okay, so this is upfront surgery. If diagnosed in the first trimester, surgery is possible, and not all patients require chemotherapy. So the low-risk patient, they may not require chemotherapy. So if they don't require the chemotherapy after surgery, maybe after 2 or 3 weeks, they will require radiotherapy. So if they have to, if they are expected to receive radiotherapy during the pregnancy, so then mastectomy is preferred, because mastectomy, if you have mastectomy, the need for radiotherapy is reduced or is obviated. You don't need to have radiotherapy. So it's not an absolute contraindication, but you have to strongly consider about doing mastectomy. If diagnosed in second trimester or third trimester, so it's not so much of a problem. So you can do surgery upfront, breast conserving surgery, because breast conserving surgery, and then you have to decide whether patients will receive chemotherapy or not. If patients will need chemotherapy, at least in the second trimester, you can wait 2-3 months. So you can delay the radiotherapy up to 2-3 months. It's still within acceptable. In third trimester, it's almost the same as a normal non-pregnant patient. So you can do the surgery and then plan for delivery and then continue with the systemic therapy after that. What about neoadjuvant chemotherapy? So cancer diagnosis in the first trimester, chemotherapy, and then we give a break for 2 or 3 weeks before the surgery. So surgery this time maybe coincide with the delivery itself, and we can continue with the endocrine therapy or radiotherapy after that. So as you can see, chemotherapy gives you some time to sort of delay the radiotherapy, which is contraindicated in pregnancy. Okay, so now we move on to how does breast cancer treatment affect pregnancy. I'm just sharing, I think, 2 trials. Which one? One is a POEMS trial in 2015, which is prevention of early menopause. So patients who undergo chemotherapy, especially, they tend to get amenorrhea. So they're trying to see how to improve this so that there's an increased chance of patients getting pregnant. So they give GnRH agonists in chemotherapy to preserve the ovarian function. So it has shown to reduce premature ovarian failure and higher pregnancy rate post-treatment and no worse survival. So it can be done. And then this is one I mentioned earlier, pregnancy outcome and safety for interrupting therapy for women with endocrine responsive breast cancer positive, which is published in 2023. So as you know, endocrine therapy, tamoxifen, letrozole, they tend to go for minimum 4-5 years. Some patients go to up to 10 years. So during this period, patients might wish to have to get pregnant. So what do we do then? So you can stop, like I said just now, for 2 to 3 months before trying to conceive, but they have to be on treatment for at least 1.5 up to 2 years before that. So no short-term increase in recurrence. There is much higher pregnancy rate, acceptable obstetrics outcome. Okay, so let's look again at the case earlier. So case 1, so we had MDT, so she was diagnosed in the 27th week, so 3rd trimester. So we give chemotherapy 3 times up until 34 weeks. Breast marker insertion because we expected the tumor to shrink significantly because she was a HER2 positive cancer. She underwent seizure at 37 weeks. Elective seizure because this is considered a precious pregnancy for her. She had 2 miscarriages before, so that's why during that meeting we thought that the ONG suggests LSAS would probably be a better chance of the fetus to survive. And then continue with the chemotherapy and the targeted therapy. We did the mammogram after that and CT scan staging. There's no metastasis, so we then did the surgery, hook wire white local, so the tumor shrink so much that we cannot palpate the tumor anymore. We need to localize it with a hook wire, and there was thankfully pathological complete response. And then she went for radiotherapy to the breast with a boost, and now still undergoing Herceptin. As for case 2 just now, if you remember, she had a breast cancer, and then she was on treatment for metastatic lung nodule, and she got pregnant during the treatment. So MDT discussion at the time, we decided that she should go for termination of pregnancy because she's still receiving the targeted therapy and IUCD. She was really 40 years old, by the way, at the time. So she was on this TDM1 until 2025. Follow-up CT shows not much tumor response. In fact, the lung node is a bit larger, so she's currently on the 2nd line treatment, TDX third line. So these are the guidelines that I refer to, NCCN, simple, easy to read. It's 2 slides amongst the rest of the breast cancer guidelines. ESCO, it's more extensive, but it's quite interesting to read as well. So these are my references. Thank you.
Thank you so much, Mr. Ali, for such an interesting topic given to us. Any questions from the floor? So far, we have not yet received any questions from the online team. It's either everyone understood everything or everyone is hypoglycemia already. So if there's no question, the floor would like to thank Mr. Adi again for giving us time to understand breast cancer pregnancy.
Thank you very much.
And now we are moving on to our next topic of the day. It will be on the primary and secondary amenorrhea. It will be given by none other our beloved Professor Dr. Ani Amelia Datuk Zainuddin. She's the head of unit of PAG unit, Pediatric Urology and Gynecology. She is a well-known PAG consultant, one of the founders of PAG services in Malaysia, our senior clinical lecturer and consultant. Please welcome a round of applause for Prof. Amelia.
Thank you, Assalamualaikum, and good morning, everyone. So today we've got a bit to go through. Amenorrhea is not an easy subject to present. So we'll try our best in this half an hour. But Abbas, you can share my slides with the participants. Yeah? Okay. So this is really the outline. Why do adolescents and adult women need